It is crucial for the pregnant individuals to attend regular antenatal checkups, early detection, management of gestational hypertension. It can help minimize the risk and ensure the best possible outcomes for both mother and the baby. So, gestational hypertension is basically very important subject. It is characterized by new onset of BP elevation after 20 weeks of gestation, often near term, in the absence of proteinuria. So, elevation of BP and absence of proteinuria. Hypertension is defined as a systolic blood pressure more than 140 millimeters of mercury and diastolic is more than 90 millimeters of mercury. On the two occasions, at least 4 hours apart and but not more than 7 days. So, patient with a gestational hypertension should be asymptomatic, though don't have any complaint, but their blood pressure is more than 140 and 190. And the diagnosis is suspected in a patient who presents with a new onset of sustained elevation of blood pressure without proteinuria in second and third trimester. It refers to the sustained elevation of systolic blood pressure more than 140 millimeters of mercury, BP more than 90 millimeters of the mercury without evidence of preeclampsia or in a previously normotensive women. It is diagnosis which should only be made after 20 weeks of pregnancy. Likely presents the exaggerated physiological response of maternal cardiovascular system in a pregnancy. Gestational hypertension may progress to preeclampsia, but preeclampsia can be excluded initially by the absence of maternal symptoms of preeclampsia and laboratory abnormalities. These are the following tests which should be sent when we see the patient of gestational hypertension. Urine analysis, 24-hour urine collection for protein quantification, creatinine clearance, CBC with platelets, liver and renal function test, and uric acids. Another important point when we talk about gestational hypertension. It is necessary to consider the hospitalization for approximately 24 hours to exclude preeclampsia. If systolic BP is more than 160 and diastolic is more than 110 on 2 occasions, at least 4 hours apart, the diagnosis is the severe gestational hypertension. Mild gestational hypertension is rarely associated with any adverse maternal or the fetal outcomes. Severe gestational hypertension has been associated with similar outcomes of the women with preeclampsia and 14 to 20% women with the eclampsia. Hence, severe preeclampsia do not have proteinuria prior to their seizures. So, testing should include non-stress test, looking the evidence of uteroplacental insufficiency, biophysical profile or amniotic fluid estimation, ultrasound estimated fetal weight or a combination of these modalities. Umbilical artery Doppler velocimetry is only useful in the settings of the fetal growth restriction is there. The treatment for the mild hypertension has not been shown to improve a pregnancy outcome, so need not to be given. Antihypertensive therapy used to prevent severe gestational hypertension and maternal hemorrhage or a stroke. There are only 3 indications for the antihypertensive therapy in the setting of preeclampsia. First is the underlying chronic hypertension. Number 2 is to achieve BP control to prevent cerebrovascular accident while effecting delivery. And third is the expecting management of severe preeclampsia. The BP criteria alone, that is a CBI protocol. In women with mild gestational hypertension, the progression of severe hypertension or preeclampsia often develop within 1 to 3 weeks after the diagnosis. So be careful. We have to be vigilant. We have to see the patients regularly. We have to do the every 3rd day, 4th day checkups of the patient. Elevated concentration of the uric acid might be a predictive progression of the preeclampsia and the risk factors for the adverse fetal maternal outcome. Delivery is the only effective treatment for the gestational hypertension and preeclampsia. It is recommended in the women with mild gestational hypertension and preeclampsia without severe features of beyond 37 weeks or beyond 34 plus minus 1 week of gestation if there is evidence of fetal growth restriction less than 5th percentile is important. If severe gestational hypertension develops, the management is similar with the women with the preeclampsia. with the severe features of the delivery is recommended 34 plus minus 1 weeks of the gestation. There is no proven benefit of routine delivery by cesarean section. However, the probability of the vaginal delivery decreases with decreasing gestational age. With labor induction, likelihood of the cesarean delivery is 93 to 97% at less than 28 weeks, 53 to 65% at 28 to 32 weeks, and 31 to 38% at 32 to 34 weeks. And this is the algorithm for the gestational hypertension. We have to take a right history, do the correct examination of the patient, which is suggestive of the gestational hypertension, do the initial evaluation, confirm the diagnosis, exclude preeclampsia, document the fetal well-being, and do not initiate antihypertensive therapy. Then if it is, there is two things we have to divide. If it's preeclampsia, we have to treat it accordingly. But if there is no evidence of preeclampsia, three things should be done. Number one, outpatient management, follow up within 4 to 7 days. And third, review the symptoms and signs of preeclampsia. If what further management is needed, weekly antepartum visits, including BP checks, urinalysis, and fetal testing. Fetal testing should not be like that. We have to do the weekly biophysical profiles with non-stress tests, serious ultrasounds, or the fetal growth should be initiated. And if there are any chances of development of preeclampsia, again, it should be treated according to preeclampsia. And if there is nothing, but only gestational hypertension, deliver the baby at 0 + 7 weeks. And if the patient develops severe gestational hypertension, management is identical to preeclampsia. So that's very, very important with gestational hypertension. Thank you.